Welcome to Living Well and Bell Hot Topics. Hot Topics are short videos on subjects that are important to you and your overall well-being. We will be talking about a wide variety of topics, from health, mental health, and wellness to cybersecurity. Our guests will be experts in their fields, sharing information with you to help you live well in Bell. Our speaker for this session will be Dr. Veronica Piziak. Dr. Piziak is an endocrinologist at Baylor Scott & White Health in Temple, Texas. November is Diabetes Awareness Month, so we are excited to have Dr. Piziak, an expert in her field, sharing with us more on diabetes.
Well, good morning. I'm Dr. Veronica Piziak from Baylor Scott & White in the endocrinology section. And this morning I'm going to talk about diabetes mellitus. What is it? How to diagnose it, how to prevent it, and what's new in the management. And finally, preventing the complications. Now remember, diabetes isn't just about your blood sugar. Diabetes is an insulin deficiency. Insulin is a hormone produced by the pancreas. When you don't have enough, it gives you a high blood sugar for sure, but also it changes your cholesterol and it decreases your ability to make muscle, so you lose weight. So it's not just your sugar that's a problem. It's also your cholesterol and your protein metabolism. There are two major kinds of diabetes. One is type 1 diabetes that's caused by autoimmune disease. Your immune system thinks that your pancreas is an invader and destroys the pancreas. And so you have an absolute insulin insufficiency, and you have to take insulin in this disease. About 5% of the people in the United States who have diabetes have type 1 diabetes, but 95% of the patients have insulin resistance or type 2 diabetes. It turns out that if you are obese or you have a positive family history of not being able to use insulin properly in your body, that you can get type 2 diabetes. So if we look on the left side of your slide, you'll see the type 1 person, and this was a 12-year-old gentleman who weighed 84 pounds. And he came to the laboratory of Banting and Best. Banting and Best were two doctors who discovered insulin. Insulin's made by animals as well, and they discovered that if they took dogs and took out a pancreas, remember your pancreas is the organ that makes insulin, that the dogs became diabetic and their blood sugar was very high. They isolated the insulin, they put it back in, and the dogs got better. And this little boy was the son of some very famous people in Canada where Banting and Best worked. And he had type 1 diabetes. And at that time it killed the children that had it because they didn't have any insulin and they eventually died. So the parents said, oh, please save our child. And this was the first human on whom they had used insulin, and he lived to be 50 years old, took insulin every day of his life. The second picture is of a patient of mine who gave her permission for this picture. And she weighs 250 pounds and she was 12 years old. And her family all had diabetes. So at the age of 12, she was obese enough that her pancreas couldn't keep up, couldn't make enough insulin, and so she also had to take insulin for her diabetes. So these are two entirely different diseases. And this morning we'll spend most of our time on type 2 diabetes, where you have insulin. Sometimes you have a lot of insulin, but it just doesn't work very well. It doesn't put the sugar into your cells, for example. And so instead of losing weight like the type 1 person, most of these people gain weight for a while, but if their diabetes gets bad enough, they also can lose weight. Okay, now let's talk about a case. This is the 46-year-old lady who came to the emergency department with a glucose of 350. She had nausea and vomiting. She was feeling ill. She has a positive family history of diabetes in her mother and her father, and she is very overweight. For several months, she's had a lot of thirst. She's been passing urine every hour, has to get up 5 or 6 times a night to pass urine. And when she came to the emergency room, she was very ill. Her family was waiting, and they said, does she have diabetes like we do? Or is this just the stress of being sick for months? So how do we know if a person has diabetes? How do we diagnose diabetes? Well, we get two things, a hemoglobin A1C and a blood sugar. So let's look at them. Let's look at the hemoglobin A1C. That's the arrows, and on your left you'll see the A1C percentage, and on the right you're going to see the sugar in milligrams per deciliter, or the blood sugar. And we use the blood sugar if it's 126 on more than one occasion, then you have diabetes. Or to diagnose diabetes, we can use the hemoglobin A1C. The hemoglobin A1C is a hemoglobin in your bloodstream that happens to pick up sugar, and the sugar sticks to the hemoglobin A1C molecule. So if you have a lot of sugar in your bloodstream, if your sugar is high, then you have a lot stuck to the hemoglobin A1C molecule, and we can measure that and tell whether or not you have diabetes. We can tell what your average sugar is for the last 3 months. And so this lady had a sugar of over 200 and a hemoglobin A1C of about 10. So both of those were diagnostic of diabetes. Hemoglobin A1C of 6.5 or more, as you can see on this slide, will give you diabetes on more than one occasion. So you have to have either A1C that's elevated on more than one occasion, a fasting blood sugar of 126 or more than once, or a combination of one A1C of 6.5% and a blood sugar of 126 or more. Or finally, and to answer the question this family had about her, a blood sugar of greater than 200 at any time gives you the diagnosis of diabetes. So, what is your A1C goal? You say, well, I have diabetes, what should my A1C be? Well, for the most part, the American Diabetes Association says less than 7 over here, which would give you less than 150 most of the time. So most people with diabetes should be in that area. However, the ADA guidelines in about 2014 and every year since have told us that your A1C goal really depends upon you. So you and your provider of care need to decide what the best A1C is for you. We need to individualize the treatment goals. And what do we look at? We look at how long you've had diabetes. The longer you've had diabetes, the more of the complications we're going to talk about you could get, so we can be a little more lax with your A1C. If you get diabetes when you're 12 years old, as our patient did, you have a long lifetime, and so we have to have much better control than if you got diabetes when you're 85 or 90 and your life expectancy was less than 10 or 15 years. In addition to that, if you already have problems, if you have problems with your heart or problems with your kidneys, or you've had a stroke, for example, then our control of diabetes can't be so tight, because if you get low blood sugars, it can make your life shorter instead of longer. And people with low blood sugars are more likely to get dementia. So we don't want anybody to have a low blood sugar. So your A1C has to be set by you and your provider. Your goal has to be decided by looking at your complications, by looking at your life expectancy, and also by looking at your support system. If you had low blood sugar, is there someone at home to help you? Well, if there isn't, then we're going to let that A1C goal ride up. So how do we do this reasonably? What are we going to say? We're going to say that we're going to look at the complication rate. How likely are you to have a heart attack or a stroke or blindness from your diabetes? If we look at a hemoglobin A1C of 7% on this slide, we see that your likelihood of complications on the y-axis is very low. If we look at 8, it goes up a little bit, right? But look, if we look at 9, complication rate is very high. So we say that people who have complications already, people who are at risk for dementia, people who who are older, their A1C should be less than 8. But if you're younger, like our 12-year-old patient, we want your A1C to be less than 7. So be sure and talk with your provider of care. You and that person really need to decide what the A1C goal is, because it isn't the same for everyone. Realistic goals are what the American Diabetes Association says we have to have. Now, let's take a look at type 2 diabetes and see if you're at risk. What are the risk factors? Well, the biggest risk factor is obesity. And these are the latest statistics from the Center for Disease Control in Atlanta, telling us about obesity in the United States. Let's look at Texas. We can't exactly hone down on Bell County on this slide, but 30% of the people in Texas report that they are obese. Uh-oh, so 30% obesity in Texas. Well, at least we're better off than Mississippi, where greater than 35% of the people are obese. Florida's a little better, and look, Colorado. These people must do a lot of walking and not eat any carbohydrates at all, right? Okay, well, be that as it may, look around. You and your provider should see if you are obese, because that's the biggest risk factor for type 2 diabetes. What's the next one? Your genes, okay? And we can't change those very much, but if you look, Hispanic adults, 42.5% are obese. If we look at the non-Hispanic white adults, as Caucasians, 34.5%, and non-Hispanic black adults, 48% obese. So again, ethnicity can give you obesity, which can give you high risk for diabetes. So look at your background and see what the problem is. Family history is the second most important risk factor for diabetes. And what's a SNP? A SNP is a DNA mistake. Remember, DNA is our genetic material, and it determines all of our enzymes, all of what we do, many of the diseases that we get are a combination of environment, that would be obesity, and problems with our family's DNA. So we're beginning to know what can cause DNA problems in certain families, and sometimes you can correct them with exercise and the proper food plan. So see, there's a way to prevent diabetes, even if you have a family history. Remember, the degree of overweight is important too. As we saw in the Black and Hispanic population and the Asian population, they are much more likely to get diabetes at a lower weight. So if you're an Asian and you're barely obese, you're just getting to obesity, your risk of diabetes is really very high. If you're a Caucasian, you can have a BMI of 30, 32, 34 before your risk is really high. So again, depends upon your ancestors and your degree of overweight. Ah, yes. Well, our dietitians have focus groups where people decide how to structure their diet. And this is the beginning of the focus group and what most of our patients munched on. And that is why 34% of our population has something called pre-diabetes. What is that? That is 1 foot on diabetes and 1 foot on a greasy French fry. That's from the CDC 2017 data. So what's pre-diabetes when we look at it in the lab? Okay, it's a fasting blood sugar of less than 126, but pretty close. And prediabetes is an A1C of 5.7 to 6.4. So remember, diabetes was 6.5. So there you are, right teetering on the edge. Prediabetes is something that frightens some of my patients. They say, well, what am I going to do? I'm going to get diabetes. This is the shape of things to come. Uh-oh, we have upper abdominal obesity. We have a family history of obesity. We have a family history of diabetes. And look at that person. Obese and using a sugar-sweetened beverage. If I'm going to tell you one thing you can do to prevent yourself from becoming diabetic when you have prediabetes, it's stop eating sugar-sweetened beverages. No sodas, sorry. So what is prediabetes again? It's an opportunity to prevent diabetes. We can do it. You can do it. And there have been lots of studies in Europe and the United States. But this is the one, if we look at in the Standards of Care of 2018 of the American Diabetes Association, and you'll notice that the people who didn't do anything, they're the placebo group. They're like that guy carrying the sugar-sweetened beverage. They developed diabetes much, much more quickly from prediabetes than the people who use metformin, which is a drug we'll talk about in a minute. But look down at the bottom at lifestyle. 58% decrease in the onset of diabetes in the people who actually did it. They got rid of the sugar-sweetened beverages. They went out and exercised. You say, oh, that sounds good to me. What can I do? All right. What kind of a food plan? Oh, what a morass. We don't have the time this morning to really get into that. But remember, that the ADA has said that the traditional Mediterranean type diet, that is a high fiber, high complex carbohydrate diet with very little meat, some olive oil there, some cheese and yogurt. Look at that. It says poultry and fish a few times per week. Up there under the red meat in the little section, it says a few times per month. Now, I realize that in Texas, a vegetarian is someone who doesn't eat meat 3 times a day. But we all have to come to the conclusion that the more plants and the more high fiber carbs we eat, the better off we're going to be. Populations who get most of their fat from vegetables live longer than populations that get most of their fat from animal sources. So do you have to be a vegetarian? No. But you should limit your red meat and eat more complex carbohydrates and more fiber. Yes, you're saying, I went on this food plan, and unfortunately, I had either I was hungry and thirsty all the time, or I was constipated. So remember, when you go on any food plan, you have to remember to drink plenty of fluids. That's 48 to 60 ounces of non-caloric beverage, or a little bit of diet beverage in there is okay, but we want a lot of fluids so you won't be hydrated. That also helps you be filled, so you're fuller. And this is Lucky the cat, and she loves to drink out of the faucet. Dietary fiber keeps you from being hungry all the time, and it also keeps you from being constipated. So 20 to 40 grams of fiber a day, and this is Corky, our dog, with his high fiber bone. He was never constipated. Okay, how about exercise? Yes, well, that's the art of converting big meals and fattening snacks into back strains and pulled muscles by lifting heavy things that don't need to be moved, or running when no one is chasing you. Oh, come on. Exercise really is part of the diabetes prevention program. 150 minutes of exercise a week. That's only 30 minutes a day, 5 times a week. And you can do that at 10 to 15 minute intervals. Well, you know, a couple of years ago, the American Medical Association decided to get together with some people and see how are we doing in exercise in the United States and what can we do to get better. And oh dear, the bottom line was get up off the couch and take a walk. It turns out that we don't exercise very much. Now, some of you out there saying, wow, no, I exercise 30 minutes a day, 5 days a week by briskly walking. Most of us, unfortunately, don't have time to do that, but do the best you can, because 10 or 15 minutes a day is much better in terms of your health than 0 minutes a day. And if you can get up and walk around a couple of times an hour, just get up and move more than you did before, is a darn good thought. Exercise burns calories, but most of us can't exercise for long enough or hard enough to burn many calories. It does improve your immune system, and good news for all of you out there over the age of 50, it also increases your mental function. Now, who of us doesn't need that? Okay. How about a medicine? You say, I like a medicine to prevent diabetes. It's so much simpler than all this exercise and food plan stuff. Well, you kind of have to combine metformin with a reasonable diet and a little bit of exercise. But you can use metformin, which is a very excellent medication. My patients are telling me lately, it's been recalled. No, only a very small part of the metformin that's used in the United States that was extended release has been recalled. Most pharmacy systems did not buy their metformin from the place in China that had contaminated metformin. So check with your provider and your pharmacy. If your metformin had been recalled, your pharmacy should have called you. So metformin is a great drug. It's great especially for people who are obese and have prediabetes, or they're older and have prediabetes. Those are the patients that most benefit from prevention using metformin. Okay, you have diabetes. What's new for you? Well, the ADA recommendations say, this last couple of years, carbohydrate counting is a good plan. You want to limit your carbohydrates, but there's no ideal diet. You say, wait a minute, I want to try the keto diet. If you have type 2 diabetes, you can try that. Be sure you get enough protein, and be sure that your fat is vegetable fat, not animal fat. Sorry, it's avocados, not bacon, that you're going to be eating here, okay? Decide what you want to do. See a dietitian. They are very skilled, and they can help you make up a food plan for life for yourself. This isn't a diet. It's what you eat every day for the rest of your life. We want to decrease the calorie intake in type 2 diabetes because 95% of those people have obesity. And again, no sugar sweetened beverages. Obviously, by the way, I'm not sponsored by the Coca-Cola Corporation. Okay. Wow, the biggest thing out there is sensors. Stop checking your blood sugar. We know it's very important to know what your blood sugar is when we're trying to treat diabetes. Obviously, we're trying to fix your blood sugar. If we don't know what it is, it's hard to fix. So patients come to my office and they say, gee, I didn't bring my logbook, or gosh, I don't check my blood sugars. And I say, gosh, I don't know what we're going to do here, Mr. Schmedlap, because we don't have the faintest idea where your diabetes is. So you have to check your blood sugars. And everybody wants one of these sensors. Oh, there's some bad news here. The Medicare requirements are that you have insulin-treated diabetes, you check your glucose 4 times a day, and you take multiple insulin injections. Some of the insurance companies have lesser recommendations, and they're lesser requirements. And so you can sometimes get away with checking your blood sugars 4 times a day and taking insulin once or twice a day. Some of them just require insulin use, but they all require you to check your blood sugars 4 times a day and make sure we know that. And once you have one of these sensors, you have to continue to do that. Your choices are the Freestyle Libre and the Dexcom G6. And the Dexcom G6 syncs with your phone. The Freestyle syncs with your phone as well now, but not quite so well as the G6. So, again, take a look with your provider and see if you qualify for one of these. They're very handy, and they allow you to check your blood sugar anytime. You just take the reader, and it will show you the blood sugar. So you don't have to stick your finger very often when you're using these. As a matter of fact, some of my patients get by for quite a few days without checking their blood sugar but with finger stick at all. The other thing that's new is that the American Diabetes Association says we ought to consider bariatric surgery for people with type 2 diabetes and a BMI of 40. So if you have problems controlling your blood sugar and you're very overweight, talk to your provider. Bariatric surgery is a good option for you. And people who have had the surgery and then followed the appropriate food plan, remember that just don't throw away your food book, your diet book, when you've had bariatric surgery. You have to follow their food plan. People who do that have gotten rid of their diabetes, and it has stayed out of their lives for up to 8 years. And that's how long the study has been going on. So again, can we cure diabetes with surgery? We may be able to cure type 2 diabetes with surgery if you follow the plan, okay? And the 2 types of surgery they recommend are either a gastric bypass or a gastric sleeve. Gastric bypass has more problems subsequently, and you have to take a lot of supplements. But again, gastric bypass works a little bit better to decrease your risk of complications and also to perhaps get rid of your type 2 diabetes. Now let's look at what's happening in insulin and oral agents. And this cartoon says that despite the valiant efforts of the research group, the insulin rectal suppository had one major problem, and it's gigantic. They're holding it up. So yes, but insulins are now, they're experimenting with oral insulins. And so that's a good thought. And they're experimenting with faster insulin. So let's see what we've got lately. What's next? Well, if we look at insulin profiles, we look at the action of insulin, we see that there are numerous kinds of insulin. And you all know about Dedamer, which is Levemir, and Glargine, which is Lantus, and they last 24 hours. There's also a new insulin, Degludec, that lasts 42 hours. That's known as Tresiba. So that's a new insulin that we can use. In addition to that, there are some fast insulins. Now, we knew there were rapid-acting insulins. They're the ones you take before meals. They're bolus insulins like Lispro, which is Humalog, and Aspart, which is Novolog. But there are new fast insulins. Lilly has one, and this is the Fastspart. So you can take them just before you eat, and they lower your blood sugars for the meal. So again, lots of new things in insulin. So ask your provider about those. But the really exciting things are the GLP-1 receptor agonists and the SGLT2 inhibitors. And you say, whoa, what are those? They're just numbers and letters. Well, let's take a look. You've seen these on television, but the GLP-1 receptor agonist is something that stimulates insulin production by your pancreas. It tells your brain not to eat so much, so it helps with weight loss. It helps your insulin work better, and it is made by you. Oh, you say, I make this? Wow, that's great. Problem is you don't make enough, and it's destroyed too rapidly. So they have long-acting GLP-1 receptor agonists. And I'm sure you've seen these on television. You've seen liraglutide, which is Victoza. You've seen dulaglutide. That's on TV a lot. And that's Trulicity. And you've seen Ozempic, which is called semaglutide. And all of those reduce A1C. That's the whole idea when you have diabetes, right? But in addition to that, they help with weight loss in patients with type 2 diabetes, significant weight loss. And this is a study that started the whole really revolution in diabetes care, because not only do these medications decrease glucose and decrease weight, they decrease cardiovascular disease. 13% decrease in cardiovascular disease, heart attack, stroke, when you take these medications. So they do great things for you. Not only that, they decrease the complication of kidney disease. So they decrease complications, they decrease weight, and they decrease hemoglobin A1C. So these are exciting new medications. So ask your provider about them. And one of them is not a weekly injection. One of them is actually a pill. Wow, that's great. You wouldn't have to take an injection. Do they have side effects? Well, yes. The duck-billed platypus, who makes a GLP-1 receptor agonist all by itself, is telling us that some people get pancreatitis. So be sure and ask your provider to talk about the side effects of these as well as their benefits. Pancreatic cancer was thought to be associated with them, but apparently is not. Okay, you say, well, how come I can't use my own GLP-1 receptor agonist? How about my own GLP-1? Well, it lasts for about 2 minutes after you eat. So, unfortunately, it's inactivated very rapidly. But another one of these new drugs stops the breakdown of your own GLP-1. So that's great. It lasts longer. It gets your hemoglobin A1C down. And it can be used even if you have kidney disease. So a good thought, sitagliptin, saxagliptin, linagliptin, I'm sure you've heard of them. And they can be used by your doctor too, but they're not as effective as the GLP-1 receptor agonists that we just talked about, and they do not decrease your risk of heart attack, and they do not cause you to lose weight. Finally, our last new medication is one that stops you from saving glucose by your kidney. Glucose is a small molecule, and it goes out in the urine. Every single molecule of glucose you took in would go out in the urine, except your kidney saves the vast majority of it. Unfortunately, your kidney saves glucose even if you are over 200. Even if your blood sugar is really high, it keeps saving glucose. It just doesn't get the picture. So we inhibit the kidney's ability to save sugar. So more of it goes out in the urine. So your A1C goes down, your weight goes down. And not only that, these medications decrease kidney disease progression and the risk of death from cardiovascular disease. So another really excellent medication, SGLT2 inhibitor. So What are their adverse effects? You got to watch it. Got to drink plenty, plenty, plenty of fluids, because otherwise the glucose concentrates in your bladder and you can get bladder infections and fungal infections. You can get dehydrated. But really, these are nice drugs. And a lot of my patients use them, drink plenty of water, and do very well. Drink fluids with these. And finally, the last thing that's new is a new way to bring your blood sugar up if it's low. If your blood sugar gets too low, you remember you're going to drink some juice, going to put some sugar in your juice maybe, drink milk. You have to work out with your provider what the best thing to do for a low blood sugar is. But sometimes when your blood sugar is very low, you don't have time to get the juice. You don't have time to mix the sugar in it. And this is a new hormone release mechanism called Baqsimi, which takes a hormone that raises sugar rapidly and puts it into a little tub, and you put it up your nose and press the button. So talk to your doctor about how to treat low blood sugars. Baqsimi is the newest thing on the market, and it works very well. You don't have to have any assistance to use it. You just put it in your nose, press the button. Finally, as we end, what about complications? What's a complication anyway? It's a disease that happens because you have diabetes, particularly if your diabetes isn't well controlled. And it's heart disease, blindness, kidney disease, and foot ulcers. You say, whoa, those are really scary. And they are, but they're totally preventable. So let's just take a look. We know that people with diabetes have heart attacks and strokes a lot more often than the major portion of our population. So how to protect your heart? Be active, limit red meat, control your blood pressure, control your cholesterol, and take a statin if you can. The statin medicines decrease your risk of heart attack by 50% and your risk of stroke by 30%. Diabetes is the leading cause of kidney failure in the United States. Type 2 diabetes, chronic kidney failure. Can you prevent that? You bet. Control your blood sugar, control your blood pressure, and avoid medications that decrease your kidney function, like non-steroidal anti-inflammatory agents for arthritis. How about your feet? Look at your feet every day. Control your blood sugars and avoid neuropathy by controlling those blood sugars and looking at those feet every single day. Blindness. Diabetes is the leading cause of blindness in the United States today. Prevent it. See an eye doctor. Control your blood sugars and your blood pressure. And be sure when you go out to wear sunglasses. If you're going to do something like mow the lawn, protect your eyes with goggles. Protect those eyes. You only get one set. Okay, well that's it, folks. We talked about diabetes, what it is, how to diagnose it, how to prevent it. Remember the high fiber and the hydration. What's new in management? These two exciting new classes of drugs that decrease heart attack and stroke risk and decrease kidney deterioration in diabetes. And we learned how to prevent the complications, controlling that blood sugar, controlling the blood pressure. That's it, folks, as Bugs Bunny would say.
Thank you for watching this session of Living Well in Bell Hot Topics. We hope you enjoyed it and learned more to help you on your journey to living well in Bell. Be on the lookout for our next hot topic coming soon. Make sure you subscribe to Temple Community Clinic's channel to keep up with all of our future sessions.